Welcome. I'm Melissa Perry. It's really good to see you and delighted to have you here for our inaugural Dean Seminar Series. Thanks for being here. The topic couldn't be more appropriate, and our guest couldn't be more appropriate to kick us off. I wanted to give you a brief introduction to Dr. Halkitis. He's an infectious disease epidemiologist, applied statistician, and public health psychologist, and he serves in these roles through his research, teaching, advocacy, and activism. Professor Halkitis is currently Dean Hunterdon Professor of Public Health and Health Equity and Distinguished Professor of Biostatistics and Epidemiology at the Rutgers School of Public Health. He's also the founder and director of the Center for Health Identity, Behavior, and Prevention Studies. For 30 years, the focus of Professor Halkitis' research has been on the emergence, prevention, and treatment of infectious diseases, primarily in sexual, gender, and/or racial and ethnic minority populations. His program of research has sought to disentangle the biological, behavioral, psychosocial, and structural mechanisms that predispose populations to infectious diseases and the synergies of infectious disease with mental health burden, including drug abuse. Professor Halkitis has authored or co-authored some 300 peer-reviewed academic articles and numerous books. Throughout his career, he has been on the forefront of fighting for the rights of those infected with and affected by HIV, as well as being an outspoken advocate for the rights and health of LGBTQ+ populations. Professor Halkitis is actively involved in all aspects of community building and empowerment through the dissemination and translation of the innovative, timely, and viable public health research that he and his research team conducts at Rutgers. He has received numerous awards from both professional and community-based organizations. He's an elected fellow of the New York Academy of Medicine, the Society of Behavioral Medicine, the American Epidemiologic Society, the European Academy of Translational Medicine, the College of Physicians of Philadelphia, and in 4 divisions of the American Psychological Association. He serves on numerous advisory boards, including the New Jersey Public Health Advisory Committee, the Behavioral Risk Factor Survey Advisory Committee, and is a commissioner on Newark's Mayor's LGBTQ Advisory Committee. Finally, Professor Halkitis is a leader in academic public health. He currently serves as the elected chair of the board of directors for the Association of Schools and Programs of Public Health. His leadership with ASPPH also includes serving as co-chair on the task force on zero tolerance for discrimination, harassment, and racism in academic public health, which engendered the report, Dismantling Racism and Structural Racism in Academic Public Health, a Framework. Today, he talks to us with a very, very important session on how racism undermines the public's health, examining the evidence and addressing hate. Dr. Halkitis, thanks a million for being here.
Thank you for having me. Thank you. I appreciate that. The dean will appreciate this because of her familiar background. But every time I hear those things, when people talk about me, I keep thinking about my Greek immigrant father who would say, "But is he a good boy?" Right? And that's certainly the case growing up with when the Greek immigrant parents, that those things mattered more. And I do think there's something to that. I'm going to come back to my mother near the end of this talk today. There's something about values and ethics that are really critical to the work that we're doing in public health that we can't lose sight of. And I will say to you that I come to this work, over the course of the last 7 years as Dean of the School of Public Health, and then prior to that, in my 19 or so years at NYU, having come into academia, not in a traditional way, being a first-generation scholar who thought, like many first-generation scholars, he had to be a medical doctor, because that's what they told me. When my parents didn't know, and figured out that eventually made his way to public health, right? And I'm grateful about where I landed, and I took the circuitous route to get there. But my work in public health and who I am as a public health researcher, scholar, educator, whatever, all the other things I am, is informed by my work as an HIV activist in the late 1980s and early 1990s. So everything I do that with that in mind. Everything I do is with the thought of the losses that we've experienced to that pandemic, but not but not only to that pandemic, to the pandemic of COVID, to racism, to gun violence, to all these health issues that continue to undermine our populations and in differential ways, affecting marginalized populations more than anyone else. All of these issues. And I'm going to come to that theme over and over and over and over again. I would also say that I want to take a moment here to acknowledge that since the word hate appears in my title of my talk, that we take just 15 seconds or so, 20 seconds or so, to acknowledge the abundant hate that is in the world and put out wonderful feelings of peace and love to the people of the Middle East, to the people of Ukraine, the people of the world. So if we could just take just a few seconds to acknowledge what's going on in the world and think about the suffering that's out there and how we can make it better. So thank you for having me here. Thank you for that lovely introduction. Thank you, Bob, for the invitation. And let me tell you what I think I'm going to do today. I don't know. It's always hit or miss with me, right? At some, we end up in a very different place than where we started. I do want to tell you a little bit about myself, a little more about myself. I want to really focus on the science that demonstrates how racism and structural racism affect the health of people and populations. I want to talk about some strategies that ASPPH has come up with, but also work that we have done in thinking about how we advance the work in research and education around racism. And then finally leave you with my theme as chair of ASPPH this year, which is around hate. So first of all, let me start by reading you this quote from writer, poet, and activist Audre Lorde, who said, "Those of us who stand outside the circle of this society's definition of acceptable women, those of us have been forged in the crucibles of difference. Those of us who are poor, who are lesbians, who are Black, who are older, know that survival is not an academic skill. It is learning how to take our differences and make them our strengths." And I love this quote because it is, the psychologists talked about positive psychology some 30 years ago. We talk about resilience now. I'll talk a little about resilience today. But how do we take our difference and make it strength? I think it's also important, this quote for me, because it addresses the thing that we need to figure out more effectively in public health is how do we address public health issues? How do we address health issues for people who have multiple intersectional identities, right? We just don't all squarely fit in a box. We come to the world, to the work, to health issues with these multiple identities. I am a first-generation scholar. I am the product of Queens, New York, like somebody else, but we're not going to say his name. I am the product of Greek immigrant parents, right? I am a person who has a public school education. I am an uncle. I am a gay man. I am a 60-year-old. I have all of these identities. 60, right? Good, right? All of these identities define who I am. And the interventions that we develop have to acknowledge these multiple identities. I spent so much time during COVID doing news interviews where people would say to me, "What is vaccine hesitancy?" I said this to some of your professors and deans before, and I would say, there's 100 different things, vaccine hesitancy. It depends on what population we're talking about. If I want to target, HIV in young Black gay men, it's going to be different than the approaches that I use for heterosexual men, right? And so I think that our work is cut out for us, right? Because in public health, we want to develop these programs, we want to develop these interventions where that's going to solve the problem for everybody, but we know that one size does not fit all. You know who also understands that really, really, really well? Educators, teachers. Teachers know that children don't all learn in one way, that they learn in multiple ways. And somehow they manage with their small salaries and their limited resources to teach kids who are coming to the world, to come into their work from different perspectives. So I put that out to you as a value system. I also put out to you this idea here, which is like, why is this like white guy up here talking to us about race and racism? And that would be a legitimate thing to actually raise. But I want to just read the first part to you and say that I was raised by working class Greek immigrant parents with a great school education in a home where we struggled to make ends meet. In my 20s and 30s, my closest friends, the ones with whom I laughed and danced, all of who once full of life, died in my presence, while many in medicine turned their backs on us. I have been called fag overtly and in subtle, insidious ways all throughout my life. My program of research has been called niche. yet here I am. It would be easier for me to say, if I can make it, so can they, but I refuse to lead with anger. And what I want to say is I also recognize that I come to this work with that allowed me to succeed because I am a white man. And despite the fact that I am a gay man, despite the fact that I am a first-generation scholar, despite the fact that I am born from Greek immigrant parents, the fact that I was a white man who passed this straight, I don't know. Some people thought so. I didn't. Opened doors for me in ways that are impossible for other people. And I need to use that voice and privilege in a really, really effective way. Right? And so I think that when I look at diversity, equity, inclusion, justice committees that exist at various institutions, we're often asking people of color to shoulder those responsibilities. And that's not going to work. We have to all be in this together. So I know we all are, because we're in public health and social work, so we get it, but we got to convince the rest of the world. That's what we have to do. We've done a lot of work at the School of Public Health, partnering with our community entities. We actually, years and years ago, called racism a public health crisis. We were among the first to do it, partnering with our colleagues at RWJ and all of these institutions. And then I have written extensively about racism in the LGBTQ population. I will tell you this story. Your colleagues who were with me before earlier will notice that I'm a storyteller because I'm a Greek and I'm a storyteller. I remember I wrote an op-ed about, racism in the gay community, right? And in the New York Star Ledger, and I went to work the next day. And somebody came up to me and said, I had no idea. And like in a whispery way. And my response was, why would gay people or lesbians or trans people be any different than people, right? They have racist beliefs, racist attitudes, racist behaviors also. And so the manifestation of racism in the gay community is actually quite if you don't buy the book, it's available free on Google. There's a great chapter in the book about race and gay men and how marginalized people tend to marginalize people. And your wonderful academic dean here has also had a great conversation with me this morning about another thought of ideas around race and racism nested within a bigger concept of status and the role that status plays. And a writer called Will Storr wrote about it. So we're trying to get him at our next conference, the role that status plays and how people elevate to a certain level and oppress the people below them. And thinking about it that way is a really interesting way to think about it also. Anyway, some definitions, because I am a teacher at the end of the day. We have to differentiate internalized racism from interpersonal racism, from individual racism, from institutional racism, from structural racism. These are different things, right? An institution can be racist, policies can be racist, people can be racist, right? And all of those things happen together to create a system of racism that exists in our society. I have ventured to say this morning that I think one of our challenges at our institutions of higher education is that racist approaches, attitudes, beliefs are embedded in many of the policies that exist at our institutions. And so if we really want to challenge racism, we have to look at those two. We have to dig really, 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 really deep. Okay, so this is the lecture part where I provide you data and stuff like that. So how racism affects health? Well, as you know, people exist in context. So racism affects people and affects population. I was talking with one of your professors earlier about the idea of an MSW MPH. Why I love those kinds of degrees, MSWs, MPHs, psychology, public health degrees, is because they give you a population perspective and they give you a person perspective, right? And the truth and the effectiveness probably exists somewhere at the intersection of those things, right? Right? Tailoring things to people while trying to address the whole population. Racism may affect the health of people, even if there are no actors within this institution. Just because we are in this space here that may not be embedded with racism, doesn't mean we're not permeated with the realities of racism every single day of our lives. One of the things I've been talking about a lot around LGBTQ issues and coming out, which is what that book was about, one of the things that was fascinating when I first wrote that book was the idea that coming out was so easy now. So much easier than for you, Perry. By the way, it was a dream for me. I had two loving Greek parents who in 1981 said, "We love you." And that was it, end of story, right? But somehow in 2020, it's supposed to be, and it's not. And I wrote that book in particular because I wanted to give voice to the experiences of young men, in this case, who are struggling with their identity, right? Who are often from immigrant families, who are often from families who are not like white, upper middle class, well-educated families, like episode 2 of the Will and Grace reboot. If you haven't seen that episode, it's really annoying. About the character who says his parents had a coming out party for him. That's not the reality for most people, right? And so I wrote that book. So I raised that issue because why does not having an actor in your environment affect you? When we think about what's going on in Florida and Texas around on these anti-LGBTQ initiatives, which interact with all these anti-racism initiatives, if you're a young gay man, if you're a young gay man of color who's like 12 years old and you're forming your identity and you're watching this and you're seeing this, it does affect you. And you could be in the most inclusive, loving environment in the world. But at the end of the day, you're sitting there and you're watching. Very much like the men of my generation sat and watched in horror as HIV was taking control. And we're like petrified. And it affected all of our lives. Fundamental causes, which by the way, until I did my MPH, I thought I had created this theory, but apparently I had not created this theory. Argues that health inequities are created by fundamental causes, and fundamental causes are those social conditions that drive things, right? So you all know this. You know, they are the distal factors that drive issues to take place. Global economic forces, socio-political forces, right? You know, in some ways, health inequity is economic inequity, right? I say that at the same time as I say this to you, which makes me wonder about that statement. We do a class every year on HIV in London for 2 weeks. And why London? Because we wanted the students to be exposed to the National Health Service, right? Which is like this really great, like health system. Great, better than ours, right? Right, there's nothing that's great. And we go there and you would think things would be better in HIV, yet it's exactly the same. And the same population, young gay men of color who continue to become infected in the United States, continue to become infected in the UK. And why is that? Because maybe it's more than just economic inequity. Maybe it's other factors too. Maybe it is the racism in those communities. Maybe it is the homophobia in those communities, but they all interact with the economic factors, right? But economics alone are not going to solve the problem. Pouring money into things alone are not going to solve the problem, right? So racism is a fundamental cause that causes these differences. Racism is one of the strongest, often interacting with SES to create these inequities, right? So yes, economics, yes, racism, yes, homophobia, yes, place, because I think place really matters, and I'll show you some pictures in a little while. But the intersection of all of those things is really what drives these inequities. So if we think about, for example, racial segregation, when you look at neighborhoods that are separated, and I don't know how many of you know New York City, but in New York City, my hometown, I'm not really from New Jersey. Let's just be clear. Just for the record, did you get that on the record? I actually grew up in a community in northern Queens called Astoria, which, you know, until I was a Greek American community, and I just thought there were Greeks in the world, and that was it. And then I went to the Bronx High School of Science, which was in the North Bronx, and I was like, oh wait, no, that's not true. There's all these other amazing people in the world. But anyway, if you know New York City, there's this guy named Robert Moses, who was this developer. And there's whole sections of New York City where he cut through neighborhoods, destroyed neighborhoods to create highways. The George Washington Bridge, the Cross Bronx Expressway, which were primarily neighborhoods that served underserved, that where underserved people lived, people of color lived. He separated them. And it created this chaos there. And this racial, that behavior and the neighborhoods that were created were so much more segregated, they didn't have access, right? And we know that racial segregation is a huge issue in creating health inequities. During the monkeypox, remember that last summer? Rough. During that little break, talk about like being re-traumatized. It was like, wait a second, not another one. The monkeypox vaccine, the vaccine was available, the smallpox vaccine was available. And, in New York City, the Department of Health was like, we're going to do vaccination clinics. And so the New York Times called me and I did an interview. I'm like, can we maybe take the vaccination clinics to neighborhoods where there are young gay men of color who don't, like, what about that thought, right? Who knows, right? And they're like, oh yeah, Halkitis, you're probably right about that. We should put that in the story, right? So the next day or 2 days later, the Department of Health scheduled vaccine clinics in those neighborhoods. You know what? They didn't require you to say what neighborhood you lived in. So all the white guys who were wanting the vaccine went up to those neighborhoods and got the vaccine, and the young men in the neighborhood who needed it did not get it. So good intention, not really well manifested at the end of the day. I think we have that under control now, the monkeypox thing, do we? I think so. I think so. The other thing that is really amazing is when you look at racial segregation. Here's the state of New Jersey. Very lovely. And this is maternal mortality in all the different regions. And if for those of you who are from Jersey or know Jersey, Jersey is like 3 different states. It's like North Jersey, Middle Jersey, and South Jersey. And South Jersey is basically Mississippi, right? But there is this amazingly bad phenomenon there, which is New Jersey is number 48 in terms of the well-being of mothers and babies. This super rich state. And it all comes back to racial segregation. And what the studies have shown, and Leslie Cantor, who is one of our faculty members, and Laura Lindbergh, another faculty member, have shown consistently, it's not because the Black mothers have less money, it's because they have doctors who are not available to them who understand them. And if you want to understand the effect that race has on maternal health and the childhood babies, watch the Serena Williams documentary on HBO. Watch those 4 episodes and watch Serena Williams, one of the most powerful women in the world, struggle to get those doctors to understand that something's wrong with her. And if she's having trouble and she eventually succeeds, imagine a person who doesn't have that level of power, what they do. And so you start to understand, again, another factor here. Oh, you said economics. Oh, you said place, right? Oh, you said homophobia. Oh, you said racism. How about the development of healthcare providers that are actually represent the population that they're serving, right? Which becomes even more challenging in the era of SCOTUS decision and what that's going to mean for all of us. So we have to continue to think about that. Here's another one of my favorite maps, or bad maps. And by favorite, I mean bad. So this is New York City. And what you hear, you can't really see it, but I'll send you the slide, you'll see it better. But I'll tell you what the story says. So these are the 5 boroughs of New York City. This is Manhattan, the Bronx, Brooklyn, Queens, and Staten Island. We're not sure why it's there. We have no idea. It's just there. And when you look at it, what you end up seeing is that in these areas, which are primarily gay areas, you get a lot of HIV infection here and here and here and here, right? But these areas are the affluent gay areas. When you look at mortality, no one's dying there. They're all dying in the neighborhoods like in the Brooklyn and the Bronx, where they are less affluent. They are people of color. The white gay men who are getting infected, who live in Chelsea and Greenwich Village, are not dying. So, but this is like 4 miles apart, 2 miles apart, 1 mile apart. Place matters. We actually did a study that was funded by the NIH called the P18 cohort study, which was a great study that we had for 10 years, where we followed 18-year-old sexual minority men every 6 months for like 14 waves of data collection, right? It was super cool. So anyway, we at baseline, we had 594 of those men who tested negative, and then we followed them to look at seroconversion. And not surprising, what we ended up seeing is that the Black men were much more likely to seroconvert than the Hispanic men or the white men, and the mixed race men, often who had part of their identity being Black, were more likely to seroconvert. Also, low SES individuals more likely to seroconvert. Okay, so what does that mean? I know what that means. That means that young, poor Black men are just not careful and they don't care. They do. They just have reckless sex. Thank you, Nicole Bobet, for that comment. But in fact, when you look at it, when you looked at something called unprotected anal intercourse, the young Black gay men, the most risky of sexual behaviors for HIV, the young Black gay men were less likely to have it. But you know what was true? They were more likely to live in a neighborhood where the HIV prevalence was uncontrolled and more likely to choose partners that were HIV positive. So if you are doing, as my friend Ron Stahl would say, swimming in a pool of viremia, then you are more likely to become infected. The Colombian undocumented individuals living in Elizabeth, New Jersey, didn't want to get COVID, but they were living in basement apartments with their children and had to go out every day to work. And so, of course, they got COVID. They didn't have the privilege of going on Zoom to work like we did, right? And so when we think about public health, when we think about the role of public health, what do we do in situations like that? It's very nice that Governor Murphy said, don't have social events with more than 10 people. I didn't know, why was 10 magical number? I have no idea. 10 people, 10 people in New York City is a lot of people because nobody has square footage there, right? Just like basically everybody lives in the studio, right? But somehow 10 people was a magical number, right? And everybody was like, okay, I'm gonna invite 10 guests on Thanksgiving. But people like the ones I just described, the Colombian undocumented individuals who were living in Elizabeth, didn't have that choice. They also didn't have a choice that they didn't have any internet for their kids to go to school, right? Public health, that's the work we have to do. We also know, of course, that there's a huge part of the racism that we experience in our country is due to cultural racism. The installation of the ideology of inferiority and the values, language, imagery, symbols, and unstated assumptions of the larger society. You know, what do the Greek people think? What do the Albanian people think? What do those Ukrainian people think? What do those Colombian people think? These are assumptions that people have, right? That create that lead to politicians creating policies that are influenced by these cultural misrepresentations and misunderstandings. There's a ton of evidence. I'm not going to read this all to you. This is just the data point I had before. 47th, I got it wrong. 47th, New Jersey has one of the highest rates of maternal death in the country, near the bottom. Women who are Black are 5 times more likely to compare to die than white women. The rate of women who suffer from severe maternal morbidity in New Jersey is compared to other states 50 to 100 times worse. Tammy Murphy, who is the first person, we've got to stop saying first lady. The first person in New Jersey is really pushing this initiative. This is also another slide here, I apologize here, that shows a very, 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 very clear relationship between self-reported health and racism. The more racism people experience, the worse mental health and other physical health issues they experience. This is another example of the effects of racism, monkeypox. Look at monkeypox. The US population is the purple bar, and here's gay men who are the population most affected by monkeypox. When you look at it consistently, look, the Hispanic men and the Black men, who are a smaller part of the population, were more likely to become infected with monkeypox, also less likely to be vaccinated. This is also a phenomenon when we think about firearm violence. And we have an amazing gun violence research center led by Mike Anestis at our university. And if I show you this slide, there is a very, very clear correlations between, for example, firearm homicide rate and the Black population. These killings are happening in neighborhoods that are primarily non-white. There are all of these factors that deal with economic realities, racial realities, where these situations occur. And this is a great paper, if you haven't seen it, published in 2020, which is about Louisville, Kentucky, where red line neighborhoods within Louisville, Kentucky in 1937 had significantly more gun violences today. The impact of historical and institutional racism on modern gun violence merits acknowledgement and further study. So they separated out the city into all these areas, they redlined them, and as a result, they created this segregation, and in those areas are the areas that you're seeing much more gun violence. So it comes back to the idea that I've lived with my whole life, the idea of syndemic. Show me mental health problems, I'll show you infectious disease problems, I'll show you gun violence, I'll show you domestic violence. They all go together. These health problems all co-occur. This is a study we did that was funded by NIAID on stop and frisk. And what we showed pretty consistently here is that young sexual minority men facing the greatest economic vulnerability and mental disorder symptoms were more likely to stop and frisk. And I showed even more. Here's odds, adjusted odds ratios here. If you are Black, Latinx, live in the Bronx, like Jenny. Does anybody know what I mean? Who gets that reference? Okay, good. Because I said Janet Jackson to my class last week in biostats, and like, no, nothing. I was talking about experimental designs and control, and I said, but not like Janet Jackson control. Nothing. Anyway, being Black, Latinx, living in the Bronx, which is, for a long time, primarily ethnic minority. The South Bronx now is completely different. It's got like condos and Targets and Marshall. It's like bizarro to me every time I drive there. PTSD, internalized homophobia, depression, and anxiety. So psychological factors, place factors, identity factors, all interacting to explain stop and frisk. If you're more likely to be depressed, you're more likely to be anxious, you're more likely to be Black, you're more likely to be stopped and frisked in New York City. Yeah, so things to consider in advancing the science around this is to moving beyond a near exclusive focus on individual racism to thinking about racism on a larger scale, right? So we have to, how do we do that? Here are some 5 suggestions or 6 suggestions I'm going to give you. Number 1, undertake behavioral and psychological studies to examine the institutional, cultural, and structural racism and their impact on health. There are very few studies on that. This is an area that we need to get the NIH to actually continue to focus on. How does institutional racism, how does structural racism affect health of individuals? Number 2, think about developmental health. The physical, mental well-being, and competence of people. Like how do we think about health holistically in people, right? So the other thing I said to your colleagues earlier was, when people say to me, blah, 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 mental health, my response is, you mean health? Why do we have to put that label in front of it so that we other it? Kind of the same thing I use. I'm sorry for those of you who've heard me say this already. When people say to me, blah, 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 community engaged research, I say, you mean research? The minute we put a label on things, we make them different. We make them othered, right? And so thinking about holistic health is huge. Resilience. So I have been making this argument for ages. When you look at the NIH and when it funds deficit, right? Okay, I get it. You got to fund disease, right? But let me think about my work. I did a lot of work around meth addiction in the early 2000s, right? And yes, 20% of gay men were using meth and becoming addicted, but 80% were not. But we were building the models on the 20%. And my point is, why weren't we building the models on the 80%? What were the 80% doing that prevented them, even if they had used meth, not become addicted to meth? What was their behavior? What was their psychology? What was their social support? What were the factors that kept them safe before they went down that horrible meth reality that you all know creates a devastating, we all saw the TV shows, right? We know that reality that they created, okay? And in fact, this resilience idea is something that was really fascinating to me. I did a lot of work in older adults with HIV, and in the mid 2000s, and then again in the 2010s, and developed this idea that resilience served as a buffer, and that if you looked at people who had resilience, they might have had better health things. Now, resilience, I will say, is one of those dual-edged swords again, right? It's like, I like people to have grit and stuff, but often people who have that are people who have been put upon in society. So it's complicated, right, to say the least. To say that, people of color, sexual minorities, women have been subjected to things that's had to make them have resilience. How about we just take away the bad situations and then everybody has an equal chance? But resilience is an interesting concept nonetheless, because it builds on this idea that people have positive aspects to their identity that can help them. That's the part I like, right? And our studies have shown consistently that people living with HIV who have this resilience are more likely to have better health outcomes. So I'm leaving that. I'll leave that for you to see. Next, something you guys do really well. transdisciplinary collaborations. Public health cannot continue to exist in its silo, right? Public health began as a profession that was about all the health professions coming together, right? And so I think it is critically important that we use transdisciplinary approaches that bring together social workers and psychologists and public health people and nurses and doctors to do this work. This is a very cool article, also available for free, that I wrote about, talking about, you know, how public health psychology, how psychological issues, how social work issues, how those kinds of issues can close the gap between medical care and public health. And I think that understanding people's psychological lives is key. The book I'm writing right now is called People and Public Health, How Americans Created the HIV and COVID-19 Pandemics. The chapter I finished last night, thank you both, in my hotel room, was about misinformation, but my favorite chapter in the book is chapter 2 about emotions. Like the emotional response people have that make them make bad health decisions. Those emotional responses are based on a belief system. Those belief systems don't come out of the blue. They occur over the course of one's life. So as public health people, not only is it not enough to give information and say, go get your vaccine, go get your booster. Like today, you only have to go 5 miles on a bus to get it, but it's okay, right? All of those, and those are things we're talking about, but we're not talking about what the resistance is, why the emotional reaction is to the vaccine, right? How the misinformation is fueling the belief system, right? And so we have to dig deeper in public health. It's not enough. The superficial, like we're gonna do clinics and stuff, is not enough. To me, the parallel here is like if you have a very, very deep infection in your hand and you just put a topical, that's not gonna work. You need an antibiotic that's gonna do deep root work. And we in public health need to dig deeper into people and to understand them. And we have to do it without judgment. This is how we lose people. Because if we're gonna say, bad person, you're not vaccinated, you're an idiot, we're gonna lose those people. That person feels those feelings for a reason. I have people in my life who are highly educated individuals who are convinced that they are convinced and they will not vaccinate their child because it will cause sterility. Thank you, Nicki Minaj, for that, by the way. But what is it about them? They're highly educated lawyers, what is it about their belief system? What is it about their lives that got them to this point? It's the same thing we have to say about racism, right? It's like people don't just one day decide they're racist, right? Or addicted. Like people don't wake up one day and say, I know, I'm gonna have an opioid addiction. That seems like a really good idea. No, there's life circumstances that get them there. There's life circumstances that make people have, racist attitudes. And maybe it's about status, right? Well, that means that it's not enough just to address the behavior in the moment, but it means that you have to go back and address the root causes of these factors. And that's hard work, but I think that's where public health needs to go to try to really make a change. And of course, education and training. So let me go to this slide then. So I had the great privilege of working on this document. And in all true honesty, when I worked on a document earlier that was about zero tolerance for harassment and discrimination when all of the Me Too stuff was going on. The morning show, who's watching the morning show? Oh, good. I hate and love Jennifer Aniston, okay? But I worked on that, and then Laura Magana, who's the head of our organization, called me and said, can you run the anti-racism room? And I'm like, no, I need a partner who is not a white man to run this with me. And my colleague, Linda Alexander, I got to work with, did this with me. And so we had this really amazing committee. And what we came up with was this vision, a blueprint for outlining the major challenges needed to rethink, rebuild processes, procedures, and policies to dismantle the conditions that enable and sustain racism in academic public health institutions and empower all faculty, staff, and students to succeed. And the model we came up with, which I think was really, really good, is to deal with the three main domains that exist in our schools, namely education, practice, and research, but also to think about all of the constituents, right? Not just our faculty and our students, but the staff and the populations we serve, and the public health workforce. And there's a series of recommendations that are part of that report when you look at this matrix together of immediate, intermediate, and long-term strategies. We at our school, not I, people smarter than me, developed this really amazing assessment on public health for our curricula, where all faculty members are required to assess their content and their beliefs about themselves, not an evaluation, not a punishment, about their curricula. And so we came up with this thing, these terms. We talked about all the dimensions of diversity, equity, and inclusion. And then basically what the faculty member needed to do was go and think through their assignments, their guest speakers, their lectures, their readings, their visual materials, making sure that the curriculum was representative of different voices. Now, when you have a dean who's got an education degree, he's going to push back and say, but there's diversity in learning style too. So it's not sufficient to have a midterm and a final. You have to give people lots of different ways to succeed. Lots of different. So if you're in my biostats class right now, you would have, I don't know, 15 different things, all worth a few points each. That allow you. One's a data analysis, one's a homework, one's an exam, one's a take-home exam, one's a little talk. Because who does well on the exam is not necessarily the same person who does well on the data analysis. So diversity, something we don't talk about enough when we talk about diversity of learning has to be part of the conversation also. So that's what this thing does. And you go and you assess yourself, and then you meet and you talk with your chair, and you're able to make modifications to your curriculum. I would say that I went into this thinking, my syllabus is perfect, and it certainly was not. And I made modifications as a result. Another way to think about it from a research perspective is thinking about a model something like this, which looks at biological, societal, and societal institutions and racism and how they fuel these paths to health issues, okay? So that all of these things, the biological characteristics, societal institutions, and racism interact to create things. And let me give me my HIV example, which is why did HIV prevail so wildly in gay men? Well, because gay men were, of course, discriminated against, absolutely. But gay men also engaged in sexual behavior that was more likely to transmit HIV, right? And we know now, 40 years later, that a certain kind of behavior, kind of anal intercourse, receptive anal intercourse, is the most likely behavior to spread HIV. So if you're a gay man, you're doing that. If you're a straight person, you're not necessarily doing that. That's not true. If you're a gay man, you're very likely to do that. And that's what caused the problem. And so thinking about biology and social conditions and racism in combination with each other is key. I said to your colleagues earlier also that in my school, because I'm the big mean dean, I'm now requiring students to take a course in public health biology, because you have to understand the biological underpinnings of disease, at least a little bit, right, in order to understand social determinants like HIV, COVID, lots of infectious diseases and chronic diseases have biological roots, right? They are driven by social conditions, but the social conditions in and of themselves are not the pathogen. And you have to understand how the pathogen works in order to understand how it interacts with these social conditions. And so we're somehow going to figure out how to squeeze that into 42 credits. And I don't know how we're doing it, but apparently we are. Somebody smarter than me is going to do it. I am informed in all of my work by this perspective. George Engel, in 1977, a medical doctor, wrote this, and he said, to provide a basis for understanding the determinants of disease and arriving at rational treatments and patterns of healthcare, a medical model must also take into account the patient, the social context which he lives, and the complementary system devised by society to deal with disruptive effects of illness. That is the physician role care system. This requires a biopsychosocial model. And for some people, the biological factors are more important than the psychological factors, but never is a health condition not informed by all three of those things. My parents, I write that in the article I showed you before, my father, who died at 57 years old, as a Greek immigrant who had a fear of doctors and an awe of doctors, and his stomach hurt for 2 years. And by the time that tumor erupted on his stomach, it was too late. And here's a white man whose fear of the medical profession and what they were going to do to him, prevent him from getting care, right? And so we have to consider social conditions. We have to consider immigration status. We have to consider acculturation. We have to do all of those things if we're going to have an effect. And of course, a syndemic approach, meaning that we have to understand that all health conditions do not happen in isolation. This is an article we wrote at the height of COVID in the early 2020s, looking at HIV. We had a model that we were working with, but we added COVID to that model. We were looking with HIV positive people. It was actually interesting during COVID. It doesn't really seem, we expected HIV positive people to have much worse outcomes as a result, and didn't really happen. We'll understand why in 20 years. I don't think we understand now. I have a hypothesis. I think for HIV positive people who are on medications and who are taking their medications, they're taking antivirals already. We know that Paxlovid was one of those antivirals. It may have been protective. The problem is that only 50% of Americans who have HIV are adherent to their medications. So the other 50% were the ones who were vulnerable. But can somebody get money for that study? Because that seems like a really good study to me. And this is actually just another model that we've been using in our site in Newark. Our school exists in New Brunswick and in Newark, New Jersey, but this is the model we've been using there. My friend Lisa Boleg wrote this in the American Journal of Public Health a few years ago, where she wants us to critically engage with theory and practice, emphasize strengths and assets, use multivariable interventions, and abandon race as an exploratory independent variable. I am particularly fond of this thing here because, as I say to my students all the time, if you show me that depression affects cigarette smoking, I can affect depression. It's malleable. But if you tell me somebody's demographic characteristic as the only explanatory factor without any social or psychological or behavioral explanatory factor, I can't do anything about that. And so Lisa talks about that very quickly and she very, very clearly in that article. And she talks about the need. We know that there's health disparities. We know. We don't have to keep proving there are health disparities. We know. It's time to move from description to intervention, right? Enough. Why are we so, like when they would call me, they would interview me during COVID. Do you know Black people are more likely to get sick? I'm like, well, again, why are we surprised here? Why is anyone surprised? We are looking at the same social conditions that fuel cancer and obesity and heart disease that are going to fuel they're going to fuel COVID-19. And so while I appreciate the fact that people are continuing to look at the differences that exist in society around health conditions, I need people to start changing it. That's where the money needs to be. And if I were running the NIH, which I will not be because I will be retiring in 5 years with my dogs at my beach house, I would put money only for intervention research at this point around those. I mean, yes, obviously for pharmaceuticals and for other things, but in terms of public health intervention work, we need interventions that work. Interventions, by the way, and I'm going to say the thing you're not supposed to say, that also are not overly dependent on these super simplistic social cognitive models. Like I love me a little health belief model and theory of reasoned action, theory of planned behavior. Really? I mean, they're nice. They work really well in research. But as I said at a conference in 1998, when I was a young, evolving scholar, and they were talking about, oh my God, this theory of reasoned action is just so powerful to explain HIV, because if you have high levels of self-efficacy, you're more likely to use a condom. And I was like, not after you've had 4 shots of tequila. Right? Because this is the disconnect between people's behavior and emotions and these models, right? The social workers here get it. You get it. You totally understand that, right? People make bad decisions because it makes them feel good. And so how do you manage bad health decision-making to become less bad health decision-making, right? Without saying you just have to use a condom every time. Because that just didn't happen, right? These are big, big, big issues that you guys have to figure out. This is your work. Like I'm almost done here. I've got the 3 white Pekingese, yes, named Charlotte, Victoria, and Albert. That's true, who are going to be at the beach with me. Okay, so final set of slides, and then I'm done. So my concluding thoughts about addressing hate. So that's a picture of me and my mother. Let's enjoy my hair here for a minute. And my mother used to say this is I come back to this idea I said to you earlier, that values that we're raised with inform who we are. My mother used to say, this word in Greek means mu, means my. So my mother used to call me Perimu all the time. So Perimu, whenever I say, I hate her, I hate him, he would say, Perimu, we don't hate, we don't like, but we never hate. And that has like stayed with me all 60 years of my life. And it informs so much of everything. So this hate effort on my part as chair is a tribute to my mother. You know, we have to recognize racism and its historical context, right? Racism and hate towards people. Racism is a form of hate, has affected the health of people and populations. And we need to recognize that hate in the United States is rooted in the enslavement of Black people, right? The destruction of African nations by the slave trade and the life experiences of African Americans through our nation's history. One of the most traumatizing moments I've had recently was when I was in Lisbon 2 years ago. 2 years ago? Yeah, in Lisbon. Well, where the guy on the bike, the guy was driving around and on a bicycle. This is not the real, I have the other story, but I'll tell you the story first. Driving us around on the bicycle and he was like, oh my God, that building over there, it's full of gold and jewelry and stuff. That just happened after World War II. We don't know why. I'm like, oh, we know why. We know exactly why that is. But the point is, that was right near the harbor where the slave ships would come in, and those buildings that are there where the slaves would go, which are now restaurants. And I thought, maybe they should have been monuments to the people who were dragged here, right? Anyway, hate. And hate attacks all of these identities. And many of us have many of these identities, right? And so minority stress theory, which is one of the theories that I actually really like, talks about the tendency of people who have multiple minority statuses to have worse health outcomes, right? If you're a young, gay, Black, not affluent man, you have 4 stressors right there. And then you live in a neighborhood that doesn't have services, you have 5 stressors there, right? And if you're trans, you have a 6th stressor there, right? And so the interaction of all those stressors undermine your health. And that's why you tend to see worse health outcomes in people who have minority statuses, because they're experiencing these stressors in society, because of their religion, because of their sexual identity, because of their gender. And we can think of hatred as an infectious disease, a determinant and a public health issue spreading violence, fear, and ignorance. And it has effects on the nervous system, the immune system, and the endocrine system. There is a deep connection between not only stressors and health, but stressors and the systems of the body. And so at ASPPH, we are addressing hate as one of the root causes of health inequities. We must address it, and we must develop and implement interventions that challenge hate. Anti-hate interventions, anti-racism interventions are one of the sets of interventions that we need to develop in order to affect public health in a way, to achieve health equity. I don't know if this is going to work. Can you click on that to me and see if I can get Corey to talk? It's on the where it says, yeah, on the blue thing here. Yeah, let's try it. No, back. Oh, this thing. See if this works. That's me. This thing. It's not going to go through. It's okay. You can hear it when you see the slide yourselves. But it's actually Corey talking about seeing the killings of young Black people, and he turned on the news, and instead they were covering the coronation of King Charles. This is about values and what matters in our society. Next slide. And so here's where we are. And next slide. Oh, thank you very much. Oh, that was me. Oh, I have the clicker too, right? Thank you very much for listening to me. I appreciate it. It's been great being here. Thank you, thank you, thank you. We have time for questions, pushback, anything you want. Ask, say, comment, please. Safe space, everyone. And you tell me who you are and what your relationship is to this group.
Hi everyone, I'm Kashmir. I'm a junior and my major is community health. The question I had, what was your purpose in doing this case study? Like what drove you? Like what made you do it?
Which study?
Yeah, the study, the racism undermines.
The initiative.
Yeah, the initiative.
That's good. Thank you for that question. Why did I choose that as my initiative? Because I think like something you can probably tell about me just from the 45 or 50 minutes you've been with me is that I have no filter. Tim knows that. And I say what I feel. And I feel that hate is the root cause and racism are the root cause of so many of these problems. And unless we say it and we own it and we do it, it's not going to change. We can't dance around it anymore. We don't have time to dance around things anymore. And that's what Corey says. Corey, as if he's my best friend. Yeah, we had drinks last night. Senator Booker says, you know, it is that very, unless we say it openly and repeat it and repeat it and repeat it over and over and over and over again, it's not going to get better. And we have to be loud and open and proud about that. For me, also very important to model as a white man that, so that I just don't depend on people of color to be making those arguments. That's what it was about for me. Thank you for that question. Hi.
Hi, as a Brooklyn girl, I gotta tell you.
Brooklyn.
Yeah, but I have to tell you, I kind of trump you. I went to Hunter, so I can't even.
College campus schools?
Hunter College High School.
What year? No, don't ask. Were you there with Lin-Manuel?
He was after me. He was like 2 years after.
So I taught Lin-Manuel.
Uh-huh.
I'm going to show off right now. Hamilton,
Yeah.
6th grade class.
Did I get you? Then we were there together because
I can just retire now.
Yeah.
Like I'm like done. He was in my 6th grade class, and then actually he called me when he was doing. Have you seen Tick Tick Boom?
Yes.
Okay, so he called me and goes, Perry, what am I going to do about this section about, you know, like who was the horrible homophobe? I'm like, you know, Helms, that's easy. Like Jesse Helms was the person who was the problem during the height of the AIDS epidemic. Anyway, he's a wonderful, wonderful man.
Yes.
Go ahead.
So what my question is, you referenced how future funding for research should really target this area. How are you finding the funding pool? Are these research ideas being funded consistently, or do you find that STEM trumps more? I mean, or is there still a consistent pipeline for this funding?
Look, so I think some of the most innovative work gets funded by foundations and private grants, but I think the NIH is beginning to think through more innovative stuff. So, for example, the NIH put a call out earlier this year that required that it was an R01 call that required work with a community-based organization, but the community-based organization had to be the funding agency. For a very, very long time, it would go to the faculty member at the school, who would then go to the cute little community members and like give them some money and throw some leaflets at them and an occasional sandwich, and it was good. This requires that it goes to them. So that's a step in the right direction. The other step in the right direction is that I saw the data, the most recent data from NIH, and it looks like that scholars of color and topics around people of color are getting funded at a better rate in the last couple of years than before. But that's the last couple of years. I can't promise you what's happening in 2024 here, okay? I don't know. But we are definitely moving in the correct direction. And in fact, last point, one of my pet peeves about the NIH has always been the panels are broken. The people who are reviewing the grants. It doesn't work. You get paid $200, you have to read all these grants, nobody reads anything, it's just a mess. They're doing a whole training of every peer reviewer that everybody has to undergo. So maybe that will help. I don't know. Hi.
My name is Peter. I'm a master's student in social work. We talk a lot about self-care and how we prevent the things that we do getting to us mentally. And I wanted to ask you how you do that, especially considering how long you've been in the field.
Love these
and
students.
how long you've been in the field and like the extreme things I'm assuming you've seen and heard. Like, how do you keep yourself like invigorated to keep going?
Wow. I would say that I am grateful every single day for this job and opportunity that I have. When I think about, again, my father who owned a grocery store and hardly have any money, and then in one generation, again, because I'm white, this happened easily, you know, I could be a dean of a school of public health. It's huge for me. So every single day I take pride in that, and I am grateful for that. I would say that's number one. Number two, I do it in honor of all the people who died during the beginning of AIDS, all these people that I lost, and think about, as bad as it can be for me, being called things and being attacked and being ridiculed, I'm alive at 60 years old. Number three, the thing that really saves me is that gym. The gym 5 days a week. This gym 5 days a week with my spin class and my Metcon class and my Tabata. I am like so careful with money. The only thing I splurge on is my $300 a month Equinox subscription, because that's my mental, and I go to therapy, of course, right? Because duh, I'm a New Yorker, of course I go to therapy. That's just like a given. I would say that the honoring of my family, the honoring of the people that I've lost, and really taking care of my physical health as a way of taking care of my emotional health is absolutely key. I love nothing more than going into a dark room with loud music on a bicycle that goes nowhere. I love it. To like some crazy Karol G mix or Rihanna mix or something like that. That makes me super happy. But there are days, I'm going to be honest, that it's really tough. Where I'm like, I just can't do this anymore. I can't do this job anymore. It's ridiculous. Like, I'm fighting with the hierarchy who don't understand anything about diversity, equity, and inclusion. And it's hard. But then I just pick myself up and do it. I try to stay hopeful, and I limit myself to 1 hour of news a night. Because that's just like too much, right? I also have Charlotte, Victoria, and Albert, and I will show you pictures if you want. They're completely adorable. What else can I tell you? Oh, I have a really good husband too. Am I supposed to say that? I have a really good husband too. Anything else? Yes, hi.
I'm also a master's student. So you had mentioned that in the future you want to see more funding going to interventions as opposed to just research, and specifically interventions that get at like that disconnect between like the just be reasonable, just do it sort of models. What are kind of some examples of like interventions that you think would be more efficient systems or models?
I think psychologically, emotionally informed models for healthcare are needed here, right? So I always make a joke about this. Whenever I go to my doctor at the beginning of the AIDS pandemic, and and he would talk to me, he would say, "You use a condom every time, right?" Yes, I'm going to go with yes on that, right? Because that seems to be the right answer, right? So instead of giving me the emotional space to be able to talk about what was really going on. And I think medical models and public health models just assume that this rational decision making, that people just make the right decisions based on knowledge. Yeah, I knew in my head what the right answer was. I knew in my head what not to do. But emotionally, people make decisions. And that's what I want. I want the embedding of psychological principles and the understanding of human emotion and human beliefs to become part of the models that we do. That's not easy. But it also means that information, while good, not sufficient. It means that I need to say to somebody, I understand why you did that. I understand that it felt, I understand that you're afraid of getting the vaccine. And not just say, you should just get it because it'll do you good. Or some kind of aspects to the intervention that understand human behavior and human emotion and don't just assume that rational decision-making is enough, right? I think like, the 12-step programs, AA, they kind of do that really well. They kind of understand the role of people's lives really well. We can draw stuff from, there's things out there. We don't have to recreate the wheel here. We just have to understand that human beings are more than just information portals, right? Yeah. Who?
Good afternoon. My name is Susan. I'm currently doing my undergrad and my grad in PH. As you are about to retire and leaving the work to us, the younger generation, to take over the public health, what advice would you give us as we are reading, as much as we are doing our classwork, we are reading your papers, your research. What advice will you give us moving forward and taking over?
Be
Thank you.
fearless. Challenge norms. Challenge the status quo. Don't assume that just because something is written, it's fact. But I would say the most important thing you need to do is develop new models for dealing with people, and do it in a fearless way, right? And recognize that public health is science for sure, and it is research, but it's also activism. So be activist in your research, right? That's what I'm asking you to do. Be brave. I think your generation's doing that, right? In a really meaningful way, a little bit. I mean, better than my generation. We're a mess. You know what I'm saying? Yeah. Mess. But I think just having that, recognizing that you can do good science, right? And still be activist. I think that's one of the things I've done best in my career, is to marry the two. To be a really, like, you can't, I have over $30 million in funding. I'm a good scientist, but I'm also an outspoken activist. And I think marrying the two has allowed me to be able to do that work really effectively. And number two, I would say, be in and for the people you're working with. Don't just assume you know. When I started working on HIV and aging in 2005, I was like, I don't know what to ask. What do I ask? What am I going to measure? So I went and spoke to people who are aging with HIV, and they told me what to ask. You need to talk about this and this and this, and I did a whole series of really cool studies as a result of that. And so that's what I did. Be of the people. Public health, right? Public health. Your generation we have to reactivate. It's our job to reactivate public health, all of us here, right? The leaders. We have to make that public health prominent again and respected again. And part of that is giving you guys the tools, y'all, sorry, not you guys, y'all, y'all, the tools to be able to speak to politicians, to write op-eds, to speak to people in everyday. Those are the tools you need. And doing chi-squares, right? You can't sacrifice one for the other, right? You need both. But I think what we've done less good in schools of public health, and what we're trying to do at Rutgers, and I'm sure you guys are trying to do here too, is have a much more activist, advocacy-based approach to public health, so that you're out there actually delivering the messages to people who need to hear them, who are the people who are affected, for sure, but also the people who are the decision makers out there. Decision makers matter. People are making decisions about our health who have no idea. Just think about women's rights. Think about it. Like, think about reproductive rights in this country. Like, who's making those decisions? So you have to be able to go to a panel and testify and be clear and be smart and be focused and be direct. That's what I would say. 5 years more, not yet. I'm not retiring in 5 more years. I think. Yeah.
We have one question from our online participants. You mentioned the need to break down silos between professions.
Yes.
What are your tips for doing that?
Well, I think we have to fund research studies that include multiple disciplines in them for sure. I think the NIH has started to trying to think about that more effectively. We're doing it at pilot levels at Rutgers. So that's number one. Number two, the interprofessional education programs that we have at schools of public health are really, really important in bringing people together. Number three, making sure our public health students have opportunities to work in clinics and hospitals and not traditional departments of health necessarily. So I think bringing people together from the disciplines in their practice experiences and in their lives, bringing grant opportunities for people to work together across the disciplines, making sure that people are learning together, that you have classes where there are social workers and there are nurses and there are doctors and there are public health people is really, really important. Because I will tell you from this HIV course we do, we always have MDs and nurses and social workers and everybody has a different perspective, right? And everybody's coming in from a different way, but at the end you have this much more holistic approach. That's how I think you do it. And yeah, that means it's difficult, right? Because we're all competing for funds at the same time, right? But if as health professions we come together as one group and advocate together, I think we'll be better off in terms of education, but also in terms of funding opportunities. The NIH wants those kinds of grants now, that they're interdisciplinary in nature.
Dean Halkitis.
Yeah.
Wow, that was fantastic. What a
Thank you.
powerful
Thank you.